I'm here to host in front of you for the session 3. I'm Dr. Awais. Most of you people must have known me since yesterday night. Before starting the session, I would request my respected panelists to come on the stage and take their seats. My first distinguished panelist is Professor Dr. Tahira. She is Dean of Gynecology and Obstetrics in Allied Hospital and Faisalabad Medical University. Professor Dr. Tahira. My second panelist is Professor Dr. Noreen Bilal. He is Head of Department Gynecology and Obstetrics in Allied Hospital 2. My third panelist is Professor Dr. Mubashara. She is Professor and Head in UMDC, University Medical and Dental College. I would like to invite Professor Dr. Nadia Awais. She is Head of Department in Independent University Hospital. I would like to request Professor Dr. Nazia Musarrat. She is Head of Department in Aziz Fatma Medical and Dental College. I would like to request Dr. Aisha Izzat as our fifth panelist. She is Medical Superintendent, Mia Trust Hospital. Our first presentation is Embarking on New Journey, Impact of Weight Loss on Polycystic Ovary Syndrome. My speaker is from Islamabad. She is Director of Endocrinology in Shifa International Hospital. I would like to request Dr. Umar Yousaf Raja to come on the stage and deliver his speech. Dr. Umar Yousaf Raja.
Thank you very much for the graveyard shift. All my panelists are female, so I'm going to discuss about the polycystic ovary syndrome and the impact that weight loss have. It's been 30 years since I've been to Faisalabad. I started my medical journey from Punjab Medical College. I was there for 3 months before moving to Rawalpindi Medical College. Let's start with a case. This is someone I've seen about 10 years ago, a decade ago in Warwick. So you can see a 31-year-old Hungarian lady. I can see with a history of menarche at the age of 11 years, menstrual periods were regular to start with, but after the birth of second child, her menstrual period became irregular. She also presented with hirsutism, male pattern baldness, acne, and currently she had 2 children. And when you look at the investigations, I mean, you see a critical classical 2:1 ratio, LH12 and FSH6. You see slightly raised testosterone levels, slightly raised DHEAS, well sterilized. She's not diabetic, and the ultrasound scan shows both ovaries measuring more than 10 milliliters, consistent with polycystic ovarian syndrome. And of course, then we need to discuss about advising her to lose 5% body weight. I've induced menstruation by giving her 10-day course of metoprolol and started her on Dinet and started her on metformin. But there are certain questions that come to your mind. So these are the questions to ponder. How to diagnose polycystic ovarian syndrome, and what are the current guidelines regarding that? Which investigations we need to consider, because so often there are a number of investigations I see in polycystic ovarian syndrome, and a lot of them are actually not necessary. And what about the treatment, especially the impact of weight loss in terms of the regulation of menses? Come to that later on. So clinically, most are using the Rotterdam criteria. So if you have got either clinical or biochemical evidence of hyperandrogenism or anovulation or polycystic ovaries, and if there's any 2 out of 3 criteria, then we diagnose our patient with polycystic ovarian syndrome. The other criteria, and that's the first criteria to be used, was NIH criteria, where there were only two criteria. So there was either the clinical or biochemical hyperandrogenism and irregular menstrual period. There is no ultrasound appearance in this definition of NIH. But here you can see the newest International Guideline of Diagnostic Criteria 2023. And here you can see that there is another criteria added for diagnosis for polycystic ovary syndrome. So either you can have polycystic appearance of the ovaries, or you can now use AMH, anti-Mullerian hormone, as a newer diagnostic criteria for classification of PCOS. And we think in the near future, maybe the AMH might replace ultrasound ovaries, because it's a lab test and is available even in the clinic settings, where for ultrasound scan, of course, you need to have an ultrasound. But importantly, whichever criteria you're using is also the exclusion of differential diagnosis. So the problem with polycystic ovary syndrome is that not only is underdiagnosed, but sometimes it's misdiagnosed as well. So it's important to think about the differential diagnosis, for example, a very mild version of congenital adrenal hyperplasia, or hyperprolactinemia, or thyroid disorders, because these can sometimes mimic as polycystic ovary syndrome. Cushing is one of them as well. But importantly, when I look at polycystic ovary syndrome, I look at the different domains. So either the person is going to present with hirsutism, acne, balding, acanthosis, so these are the symptoms due to excess androgens, or they can present with the reproductive symptoms like infertility, miscarriages, or if they become pregnant, then they can present with preeclampsia or gestational diabetes, or there are metabolic complications like obesity, type 2 diabetes, MESR, hypertension. But importantly, there are also the mental aspect of polycystic ovary syndrome, like anxiety, depression, sexual dysfunction, or disordered eating. This is important. Again, this is the International Diagnostic Criteria 2023, so there are diagnosis steps. So if someone have got already a clinical history and examination of irregular cycles and clinical evidence of hyperandrogenism, so male pattern bordering, hirsutism, acne, then you might not need any other investigations, and straight away you can diagnose them with polycystic ovary syndrome, provided that you rule out by doing TSH, correcting 17-hydroxyprogesterone, other differential diagnosis of polycystic ovary syndrome. If they have got one of those symptoms, then you might go to the step 2, which is where you have to do a free testosterone or free androgen index, and in selected cases, maybe androstenedione or DHEA4. And then, if only there are irregular cycles or evidence of hyperandrogenism, that's where the ultrasound for polycystic ovary syndrome or AMH might be helpful. Now, look there that for adolescents, ultrasound of AMH is not indicated. You can only label them as a risk of polycystic ovary syndrome, and you can reassess them back once they become adult. So try not to label the adolescents with polycystic ovary syndrome, because they do have quite common the ultrasound appearance of polycystic ovary syndrome, and they might be misdiagnosed with the diagnosis of polycystic ovary syndrome. What about the health implications? And here you can see I divide them into the gynecological health implications, such as menstrual dysfunctions, infertility, endometrial pathology, and pregnancy related. And then there are the non-gynecological burden. And as an endocrinologist, we are mostly concerned with these sort of aspects: hyperandrogenism, metabolic disturbances such as dyslipidemia, dyslipidemia, metabolic syndrome, sleep disorders, and then there is a theory about cardiovascular risk and cognitive risk as well. For me, the important investigations is actually the testosterone level, thyroid function test to rule out any thyroid disorders, prolactin. Estrogen is helpful because one of the commonest differential diagnoses is functional hypogonadotrophic hypogonadism, and that's where the estrogen helps me to differentiate between polycystic ovary syndrome or functional hypogonadotrophic hypogonadism and HB1C to look at the metabolic complications. And then on the other panel, you can see the optional one. So based on the person you're seeing, you might consider about arranging an ultrasound scan of pelvis, LH, FSH, AMH, 17-hydroxyprogesterone, specifically got a very high index of 21 hydroxylase deficiency, the mitral version, sex hormone binding globulin free androgen index levels, and in few selected cases, especially if their testosterone levels is too high, then DHEAS4 and testosterone might be helpful to rule out any adrenal pathologies or adrenal cancers, as well as ovarian cancer. So what about the treatment? When I look at PCOS, I normally think about where does the problem lies. Does the problem lies with the androgenic symptoms? Does the problem lies with irregular periods? Or it does lie with infertility? Here you can see the treatment options. For irregular periods, weight on exercise is highly effective if they are overweight. You need to think about using contraceptive pills. If they want a regular bleed, then cyclical estrogen progesterone is helpful. If they don't want to bleed, then you can go for continuous estrogen, and every 3 months you can add a sort of progesterone. Metformin have only side effect here. It's ideal if there is a glucose intolerance or diabetes mellitus. For infertility, again, weight loss and exercise is highly effective. Bariatric surgery in selected cases can be considered. Ovulation induction, either with promethazine or FSH analogs, or IVF in few selected cases. We show them that they normally have a good prognosis, so you are looking at average 1.8 children per patient. But the most important thing, and that's the roadside treatment, is the weight loss. And here you can see that losing even 5 kg of body weight will lead to less testosterone level, improvement in insulin sensitivity, and hence all of the complications of polycystic are going to improve, such as excess weight, type 2 diabetes mellitus, increased risk of fatty liver disease, as well as the reproductive implications. So what about lifestyle interventions? So lifestyle intervention should be recommended for all women with PCOS for improving metabolic health, including their central adiposity and lipid profile. The healthy lifestyle behavior encompassing healthy eating, physical activity should be recommended for women with PCOS to optimize their general health, quality of life, body composition, and weight management. This is a busy slide, but you can see this is a Cochrane review. And basically you're looking at the impact of lifestyle changes on the treatment. So the important thing is that whether it's the effect on the metabolic outcome, you see a moderate effect. So here you can see on the metabolic outcomes such as the effect on BMI, on weight, you will see some slight improvement, as well as the effect on the reproductive outcome. So here you can see again the clinical as well as the biochemical evidence such as free androgen index or the Ferriman-Gallwey score for hirsutism is mildly improved with the lifestyle changes. So here on this slide you can see the different studies of the impact of lifestyle changes. So whichever study you're looking for, I mean, these are small scale studies, you're looking on average of 3 to 6 month duration, you're looking at about 5 to 10% weight loss, but importantly you're looking somewhere between 50 to 75% improvement in menstrual irregularities and about 20 to 30% improvement in free androgen index as well. And again, the same thing is reproduced in the adolescents, youth as well. So here you can do 2 studies. Both studies is about 3 month or 6 month old studies of intervention, and here you can see again that there is around about 59% decrease in free androgen index and over 100% increase in menses regularities. What about insulin sensitizer? So we knew insulin sensitizer like metformin improve menstrual cyclicity by 30-50%, improve hyperandrogenism, also improve infertility management like improve ovulative response. It's a first-line treatment for overweight or obese, but it's also important for metabolic improvement such as reduced craving for carbohydrates, reduce weight gain, improve lipid profile, improve glycemic profile, and lower insulin levels. Okay, what about anti-obesity medications? So, the New York guidelines do mention about anti-obesity medication like liraglutide, semaglutide. as well as Oristat can be considered in addition to active lifestyle intervention for the management of higher weight in adult with PCOS as per general population guidelines. However, it's important that if you're studying them on GLP-1 agonist, if pregnancy, you need to advise them that there is no data regarding use of these agents in pregnancy, so contraception should be considered, and as the pregnancy data is lacking. So what about the specific evidence? So here you can see the evidence of exenatide. So these are randomized trial of exenatide, metformin, or exenatide and metformin. So again, you can see with the combination of exenatide and metformin, there is about 5% weight loss, with a weight loss of around 5.6 kilogram. And the biochemical markers have improved, so total testosterone, free androgen index, hormone index, and OGTT. But more importantly, you can see that there was an 87% improvement in ovulation with a combination of exenatide and metformin, small numbers. What about liraglutide? So there are two trials. The first trial is use of liraglutide in 65 women, 26 weeks trial. The weight loss of 5.2 kilogram, and you can see that there was a reduction in free testosterone, reduction in ovarian size, as well as a trend for decreased AMH levels and androgen follicle count. And from a metabolic perspective, there was a reduction in HbA1c and improvement in liver fat. Then there was another randomized trial where liraglutide was compared with metformin, or there was a liraglutide plus metformin arm. It's a 12-week trial on 40 women. You can see on the combination trial, there was around 6.5 kilogram weight loss. However, there was no change in androgens or no change in menstrual frequency. So it was an active trial. What about semaglutide? So there you can see this is a in-clinic observation trial. So women who failed to lose weight with diet or lifestyle, they were treated with 0.5 milligram weekly semaglutide for 3 months, and those who respond was given semaglutide for another 3 months. So out of total 27 patients, there was about 8% weight loss, and then 21 continued for another 6 months, where you can see 16% weight loss, and you can see 78% normalization of menses. There is another study on oral semaglutide. So this is patients who are compared with diet, and they were initially started on oral semaglutide 1 milligram for 3 months, and then 7 milligram for another 3 months. So you can see the weight loss, but look at the change in free androgen index with oral sema. So those who lose more than 10%, there was a 4.3% reduction in free androgen index, and there was a 78% improvement in menstrual frequency. Those who lose more than 5% weight loss, there was a 56% improvement in menstrual frequency. So there is some data in terms of using of GLP-1 agonist in Polycystic Ovary Syndrome. And again, that's mostly due to the weight loss. What about bariatric surgery? So just 2 slides. So bariatric surgery should be considered to improve weight loss, hypertension, diabetes, hirsutism, and irregular menstrual periods. It should be informed by general population guidelines. So in our population, usually we should cut down the BMI by another 2.5 kilogram per meter square. And we should remember that PCOS is a metabolic condition, so it should be considered as a lower indication for BMI threshold. So in Pakistani population, even as a BMI of 32.5, if they have got Polycystic Ovary Syndrome. So here you can see the evidence behind bariatric PCOS. So 36 women, age 27 years, BMI was 43.6. 61% have sleeve gastrectomy, 39% gastric bypass, and you can see their BMI have gone down, their sex hormone binding globulin improved, their total testosterone level reduced, and their ovarian volume improved. So to conclude, number one, there is a different criteria for PCOS, and there is a new evidence or new inclusion of AMH as a diagnostic criteria for Polycystic Ovary Syndrome. So we should be considering now about role of AMH versus perfect ultrasound scan. But importantly, we need to execute differential diagnosis. These are the investigations, these are quite important. So estradiol, testosterone, TSH, HbA1c, prolactin. And regarding treatment, remember the weight loss is considered rose-right treatment for Polycystic Ovary Syndrome. So not only diet, but we need to think about metformin in selected cases, anti-obesity medications, And in few cases, even bariatric surgery might be helpful because that the weight loss is the key to treatment of polycystic ovary syndrome. Thank you very much.
Thank you very much, Dr. Umar Yousaf Raja, for your excellent talk. My next lecture is about pregnancy and diabetes, screening and implication. My speaker is Professor Dr. Rubina Suhail. She was professor in Services Institute of Medical Sciences, and she is the pivotal one in the initiative of Mahfouz Ma program. So I will invite Professor Dr. Rubina Suhail.
I think.
Bismillahirrahmanirrahim. So close to lunch, if there are so many people in the hall, I think one should feel privileged. So thank you very much everybody for being here. And thank you very much the chairs of the podium for inviting us to give these talks on gestational diabetes. So me and Professor Farooq Zaman have actually divided our talk a little bit. So I am going to talk about gestational diabetes, screening implications, and he will take it on from there, I think. So the important thing to understand is that gestational diabetes is a very common happening for obstetricians, because most of our patients who are coming to us and presenting with pregnancy, when we screen them, we will find that they have gestational diabetes. And our biggest challenge is that they do not sometimes understand, despite repeated counseling, what an important issue it is and what are the implications not only for the women but also for the baby who's about to be born, and what are the long-term implications. So I think that this topic will be of interest to the audience, and the outline of my presentation will talk a little bit about the burden of gestational diabetes in Pakistan, the screening strategies, the factors which affect gestational diabetes and implication of diabetes both for the mother and the baby. Now, we are aware of the fact that the prevalence of gestational diabetes is actually, it's very variable. And if I can say that it is around 4 to 60%, it would not be wrong, because that is according to the studies. But if you look at your own clinical practice, most of the patients who have been screened for gestational diabetes will actually turn out to be diabetic, and I would say that the incidence probably would be up to about 60 to 70%, which is very, very high by any standards. So according to the data, the maximum incidence of gestational diabetes in Balochistan, which is about 36%, and I think I'm not changing my slide, sorry. Let me take you, sorry, because I was looking at my own screen, so I just forgot to move the screen. So, Balochistan has got the highest incidence of gestational diabetes in Pakistan, which is of the order of 35%, and that is what we should keep in mind. But as I said for Punjab, I think that the data is not enough, and maybe this is an idea that we need to do a couple of studies to see what is the prevalence of gestational diabetes in our population. So when I'm talking about diabetes, I think it is important to talk about screening for diabetes. So there are various investigations which are available for screening of diabetes, and the question many a time arises that first of all we have to decide that who are the people in whom we want to screen for diabetes. So if we look at the women of increasing maternal age and weight of the women, previous history of gestational diabetes, previous history of macrosomic infant, previous stillbirth or bad obstetrical history, a family history of diabetes, and the last but not the least, the ethnic background. So women in South Asia actually, in addition to all these factors, are all prone to diabetes. So if I can say that screening for diabetes is not related to one particular group, but in Pakistan, screening for diabetes should be done in all pregnant women, irrespective whether they have got a good obstetrical history or a bad obstetrical history, and irrespective of what their age and parity might be. So this is an important message for us. The second thing is that there are various investigations available for screening of diabetes. The most popular in Pakistan are oral glucose tolerance tests, 75 grams, and this is the most commonly performed. But FIGO actually has introduced another test, because When we advise patients the oral glucose tolerance test, they have to come prepared from home, or they have to get the investigation and bring the report. So some patients are going to be lost for follow-up. And in order to avoid that and to be able to understand the issues related to blood sugar screening in third world countries, FIGO has come up with a plan. And the plan for FIGO is that when the woman presents to you in the OPD, she's not prepared. So she might have taken a Brefcus 1 hour back or 2 hours back. So without any preparation, you give the woman 75 grams of glucose and test the blood sugar level 1 hour after that. If 1 hour after that the blood sugar is more than 140 milligram per deciliter, then it means that the screening for diabetes is positive and you need to start monitoring the patient. So FIGO is recommending this test, but most of the time, most of us are doing the 75 gram oral glucose tolerance test. So this is a busy slide, but it is basically talking about the screening of diabetes by the OGTT. So this is basically the method of oral glucose tolerance test for those people who are interested in it. There are two very important things which are very difficult to do. First is that the woman should be taking carbohydrates intake of at least 150 grams per day for 3 days. So most of us do not actually follow that guideline. Then fasting for 10 to 16 hours. Again, if the woman fasts for 8 to 10 hours, that is generally considered enough. And the rest of the test is the same. So you do a fasting level, then give glucose, and then a 1 hour and 2 hour level. Now, it is actually important to understand, and here I would like to add something from my own experience. So, gestational diabetes is diagnosed if the fasting blood sugar is more than 95, 1 hour more than 180, and 2 hour more than 155. But there is this group of women who fall into the impaired glucose tolerance category. And according to my experience and what we are practicing in Hamid Latif Hospital, we see a lot of women who fall in that category of impaired glucose tolerance. And if you ask those women to monitor their blood sugar levels, many a times you would realize that their blood sugar level is actually coming in higher and higher, unless you counsel them about the diet and also talk to them about their physical activity. So I think it is very pertinent that when the women come to us with impaired glucose tolerance, we talk to them about what is to be done and the possibility that they are going to become gestational diabetics very soon. This is just a summary of the FIGO method of screening for gestational diabetes, which I already talked about. Now, the question arises that when should we screen for diabetes, and there are multiple areas where we should be screening for diabetes. So in an ideal situation, when women are planning a pregnancy, they should be screened for diabetes. The issue is that in our country, very few women are actually coming to us when they are in the planning stages of pregnancy. Women who have had previous history of gestational diabetes should also be tested before 15 weeks of gestation. Limitation obviously is the nausea and vomiting that happens in the first trimester, so you have to wait for the first trimester to end and then think about it. And the most commonly prescribed screening for gestational diabetes is between 24 and 26 weeks of gestation, which is the standard recommendation in which every woman should be screened. And women who become gestational diabetic in pregnancy should also be screened 4 to 12 weeks postpartum. And an important message that I want to give over here is that when we sometimes do even screen our women 4 to 12 weeks postpartum, but then we send them home. So it is seldom that we tell them that there is a probability that they will develop diabetes mellitus. So it is very important that they should be screening themselves every 3 years, and I think that is one of the messages that I want to give today. Now, just let's quickly go through the factors which are actually going to increase the risk for women of developing gestational diabetes. Now, we do know that family history plays an important part, but there are other things, and some of these risk factors for gestational diabetes are actually modifiable risk factors, and we need to look at the modifiable risk factors. So obesity is a modifiable risk factor, age may not be, but obviously increasing age increases the possibility of gestational diabetes. A history of Polycystic Ovary Syndrome increases the possibility of developing diabetes during pregnancy. Pre-diabetic stage increases the probability. Weight loss surgery, I don't know how, but there is data available that sometimes weight loss surgery can be associated with greater probability of gestational diabetes. Previous pregnancy with diabetes, giving birth to a baby more than 9 pounds in weight, and excessive weight gain in the first trimester in pregnancy. So I think that there are two very important factors that I mentioned over here, and I would just like you to have a look at those two very important factors. This is the women's nutritional status according to the Pakistan Demographic and Health Survey. Now, what is the status showing us? That there are actually less women who are in the normal BMI range, and we have got a significant number of women who are either overweight or obese. So if a woman is starting her pregnancy when she is overweight or obese, the probability of developing gestational diabetes will increase. So this is one piece of information which we should have as OBGYN professionals, but which healthcare providers at the primary level need to have, and they should be talking to young girls about managing their weight before becoming pregnant. The second thing I think which I want to talk about is, if the woman starts her pregnancy with an increased weight, what are the implications of that weight on her pregnancy status? So there are implications in terms of developing gestational diabetes, developing pregnancy-induced hypertension and preeclampsia, difficult delivery, increased rates of cesarean section, and failure of establishing lactation. So there are quite a few implications for the pregnant woman when she becomes pregnant if she was, before pregnancy, she was either overweight or obese. And in addition to that, obviously, there are general effects of obesity on multiple system disorders, and I think I don't need to go into that detail. Now, the second thing is, which is very important, because we know that we are in a culture where eating is encouraged in pregnancy, and the mother-in-law, the mother, everybody is saying that you need to eat more, and you're eating for two. So my message to the audience today is that the message that we need to give out is that the woman does not need to eat for two in pregnancy, and she's actually eating only 200 extra kilocalories than what she was doing before. So NICE has basically dispelled the myth that women should eat for two during pregnancy. There's another thing which I would like to talk about, and that thing is that there are studies available and which data available which says that excessive gestational weight gain in the first trimester is associated with a greater probability of developing gestational diabetes. So if there is excessive weight gain in the first trimester, 80% association of developing gestational diabetes, I think, which is significant and which explains the fact that why do our women become diabetic when they are pregnant. Now, coming to the last one-third actually of my presentation, that we all know that there are adverse outcomes and relationship of gestation diabetes. The question arises, most of the times the adverse outcomes that we are thinking of are actually related to the mother and the baby, but during pregnancy and very soon afterwards. That is what we are normally talking about. So all of us know that when there is gestation diabetes, there could be adverse outcomes in terms of, as I mentioned before, diabetes, hypertension, preeclampsia, increased probability of cesarean section. And for the baby, difficult labor for the mother and for the baby, macrosomia, shoulder dystocia, neonatal hypoglycemia, hyperbilirubinemia, and operative delivery. But what am I telling which is new? There's nothing new to this information. All the OB/GYN which are sitting over here, and I'm sure the physicians too, would be aware of the fact that gestational diabetes is actually going to adversely affect the outcomes both for the mother and baby. But the message that I want to give across today is a little bit different, so I'm going to reach that in a little while. Just to reiterate a couple of facts, 50 to 70% chance of the woman developing gestational diabetes in subsequent pregnancies is the information that we need to know. 40 to 60% probability of developing type 2 diabetes in the future. And most of the time it happens within the first 5 years when the woman completes a family. These are the effects on the neonate, which are in terms of perinatal death, and we all know that we have got a high rate of perinatal mortality in our country, preterm birth, difficulty in breathing, hypoxia, macrosomia, polycythemia, jaundice, congenital malformation, hypoglycemia, hypocalcemia, and hypomagnesemia, a long list. But where do I want to take you from here? And this is where I want to take you, and this is actually an editorial which was published in 2020, and I'm going to refer to that editorial for the rest of my presentation. So recent research has basically shown that gestational diabetes does affect the mother and the neonate, but it has long-term consequences, both for the mother and for the baby, and that is important to remember and to register. Now let's look at the long-term consequences for the mother, which are many. This is a time and age when women 40, 50 and 60, we think that they're pretty young at that point in time. But we fail to realize that multiparity, gestational diabetes happening frequently is going to affect the quality of life of the woman as well. And obviously when the quality of life is affected, there's greater probability of her dying before her time for death. So the long-term consequences are type 2 diabetes in the mother, which is a 7-fold increased probability, increased probability of cardiovascular disease, increased incidence of malignancies like endometrial cancer, ovarian cancer and breast cancer, ophthalmic disease, greater probability of developing glaucoma, diabetic retinopathy and retinal detachment, and long-term renal morbidity is also associated with it. So some of those things you can actually relate directly to diabetes, but there are others which you might not be able to relate, but which are still pretty significant and we should be thinking about them. Now let's look at the long-term, just a couple of more slides. Now let's look at the long-term consequences for the offspring. And if you look at the long-term consequences of the offspring, they are very, very significant because a new life is beginning, and this is the quality of life which I as a pregnant mother is going to give to my baby. And that is the message which has to be transmitted. So they are glucose intolerance, 5 times greater risk, obesity, strong implication, endocrine morbidity, cardiovascular morbidity, neurodevelopmental outcomes and neuropsychiatric morbidity associated with it, and ophthalmic disease. So there is so much burden that we are passing on to our offspring, जिसको माँ जान से भी ज़्यादा प्यार करती हैं. So we need to tell them that this is the effect which is going to happen if we don't control the disease properly. So the grand challenge currently, I think, is to use this information to move towards secondary prevention for the mother and child. And that actually brings me to my last slide, which are the key points in the presentation. So all women need to be screened in Pakistan. We need to do detailed counseling for weight gain in the first trimester of pregnancy, and the earlier in pregnancy it happens, the better it is. Gestational diabetes has got short-term and long-term implications both for the mother and baby, and these implications need to be transferred in terms of information to the mother and the father both. So we need to focus on secondary prevention for mother and child, and the onus lies on the healthcare provider, which is us, to be able to talk about the burden of this disease and do something about it. Thank you very much.
Thank you very much, Professor Dr. Lugina, for your insightful talk about pregnancy, diabetes, screening and implication. My next speaker is Professor Dr. Sardar Muhammad Al-Farid Zafar. He is Principal PGMI. His topic is Polycystic Ovary Syndrome and Metabolic Syndrome. Professor Dr. Sardar Muhammad Al-Farid Zafar.